Welcome everybody who's coming into the webinar. Just give people a couple more minutes to get settled before we start. And we didn't actually plan it this way, but today is Giving Tuesday, and so preemptively, in gratitude for the work of the folks at the MS Center, if you are so inclined, you can use the QR code on the screen. We'll show it again at the end, but we will get started here with our presentation in just another minute. All right, I think we can get started here. Thank you everyone who has logged in already and maybe has a few more trickle in, but my name is Tom Harmon, Executive Director for Development here at Mount Sinai. I have the pleasure of working with the fine faculty and staff of our Multiple Sclerosis Center, the Corinne Goldsmith Dickinson Center for Multiple Sclerosis here at Mount Sinai. And without further ado, I'd like to turn it over to our director, Dr. Fred Lublin, the Saunders Family Professor of Neurology, and like I said, the director of the Corinne Goldsmith Dickinson Center for Multiple Sclerosis. Dr. Lublin.
Thank you, Tom, and welcome everyone. We're delighted to have you on board for our annual post-ECTRIMS conversation and discussion about what's new in multiple sclerosis. ECTRIMS this year, which was in September in Copenhagen, had over 9,000 attendees and has become really the major MS meeting of the year, eclipsing all others for that matter. And this year was an especially exciting one with some very interesting information that you'll hear in more detail, including the rolling out of new diagnostic criteria that you're going to hear more about, some new clinical trial data that you'll also hear more about, but we also had conversations around the clinical course of multiple sclerosis, and some plans for the upcoming year for changing the course characterizations to make them a little more biologically based, but also more dynamic. And in addition, we'll be talking more about what happens before multiple sclerosis expresses itself, something called the multiple sclerosis prodrome, which are vaguer symptoms, not necessarily related to the nervous system directly, that occur more frequently in patients who are destined to develop multiple sclerosis. We're developing more genetic information and more environmental information. There's been more talk about the Epstein-Barr virus and how probably exposure to that virus is a necessary component of developing multiple sclerosis, but also probably not the cause of multiple sclerosis. In addition, there's some terms that you may hear that are worth discussing. One is called RAW, which is relapse-associated worsening. And that is when someone has an attack, if they don't return to their baseline and it has some residual impairment, that's called RAW. And then there's a second term called PIRA, progression independent of relapse activity, that occurs in the more progressive stages of MS, which is some increase in impairment that's unrelated to any of the relapses. And we're working on seeing how we can more directly impact both of those causes of impairment. We also had conversations on more information on neuromyelitis optica, NMO, and also MOG-associated disorder, MOGAD. And so I'm going to turn this over to my colleagues for more specific comments, but I will tell you that very exciting today, led by Dr. Krieger, who's on this webinar. Our newsletter has been reestablished and as an online presence, and we're very excited about that. So if you did not receive our newsletter today, please respond to the invitation to this webinar, and we'll get you on our mailing list. It's really nicely done. And so we're grateful to Stephen and to Julie for organizing that. And now I'm going to turn it over to the medical director of the CGG Center for Multiple Sclerosis, Dr. Aaron Miller.
Thanks, Fred. Nice to have all of you with us today. And it's always fun to talk about ECTRIMS, which, as Dr. Loveland said, has become the most major MS meeting. I want to talk a little bit about a presentation of what we refer to as the revised McDonald criteria. So for those of you who already have a diagnosis of MS or whose loved one has a diagnosis of MS, this might not seem too important, but for the field, it's critically important because we know that we want to treat patients early with MS, but we don't want to treat patients with MS medications, all of which carry some degree of risk if they don't actually have MS. So there's always a tension between being able to diagnose the condition early and diagnosing it accurately. So the McDonald criteria are a set of criteria that initially were developed in 2001 or published in 2001 by a panel that was chaired by a distinguished British neurologist named Ian MacDonald. Dr. MacDonald sadly passed away not terribly long after the criteria were published, and they've subsequently been named in his honor. Dr. Loveland, I'm happy to say, has been one of only 3 people that have been present in all 5 iterations of the McDonald criteria, the latest one now being referred to as the 2024 McDonald criteria. I had the privilege of participating in the last 2 revisions of the criteria. So one thing that I want to emphasize is that the new criteria don't take away the diagnosis from anybody. The last set of criteria were developed in 2017, and they were extremely useful. And anybody who met the 2017 criteria still meets the 2024 criteria. So the main thing that the 2024 criteria have done is allowed us to utilize some new techniques, particularly what we refer to as advanced imaging techniques, advanced techniques used with MR. Now, some of these techniques are so recent that they're not yet commercially available. So in part, the panel was looking forward because we anticipate that these MRI protocols will come into commercial use hopefully over the next year or 2, and will enable a specific diagnosis of MS to be made in some patients where we weren't quite certain about things. MRI, of course, is critical in making a diagnosis of MS, but it's not always specific. So we have to look at the pattern and the location of lesions on MRI to be sure. And one change that was made in the new criteria is that for people who are older, over the age of 50, or who have certain other conditions, in particular migraine headache, we've required a little bit more stringent evidence on the MRI to be confident of the diagnosis. Another circumstance in which the criteria have been changed is we've recognized for quite a number of years now a condition that's been referred to as the radiologically isolated syndrome. That refers to people who come to the doctor complaining of something, but the doctor doesn't think that the patient has no reason to believe the patient has MS, and the patient gets an MRI scan. Most commonly, it's done for headache, migraine, or for minor head injuries. And then the MRI looks like the MRI of a person with MS. We've been unwilling in the past to call those patients MS, even though those of us working in this field often recognize that this clearly is MS. But with the new criteria, in at least some of those patients, we will now call a spade and say, in fact, you have MS, which may or may not lead to a decision to initiate treatment at that point. So one of the reasons these criteria are important, not only in making accurate diagnosis for clinical situations, is we want to make sure when we do clinical trials, which is the sort of the cornerstone for developing any kind of therapy, is you need to include patients who actually have the condition. If you put people in who don't have the condition, you're going to mess up the trial and get inaccurate information. So the one presentation at ECTRIMS had an unveiling of these criteria. There's going to be a fairly intensive campaign over the next year or longer to try to educate the world's neurological and medical community about how to use these criteria. I want to turn now on the subject of clinical trials to talk about one trial that was done. And this is a trial of high-dose simvastatin. Simvastatin is one of the statins that's used to treat, to lower cholesterol. And this class of drugs have many properties other than lowering cholesterol, including some anti-inflammatory properties. So a number of years ago now, probably pushing close to 10 years ago, what's known as a phase 2 trial of high-dose simvastatin was undertaken by Professor Jeremy Chataway of London. And that phase 2 trial was positive. Phase 2 trials are the next to the last level of testing medications. And when they are used in MS, they typically are shorter than the more definitive phase 3 trials, and they use an MRI endpoint rather than a clinical endpoint. In order to get a drug licensed in the United States, the FDA requires demonstration of clinical benefit. They won't accept changes on the MRI, but MRI changes can be seen more quickly and require fewer patients to be used. In the case of simvastatin, this was being studied in patients with secondary progressive MS. These are people who have once upon a time had relapses, but are now getting generally insidiously worse. And the phase 2 trial was positive. It showed less reduction in brain volume in those patients taking high-dose simvastatin. So we were very encouraged by that trial, to the point that I've offered some patients with secondary progressive MS to use simvastatin off-label, since the drug is available. It took a long time actually to get the phase 3 trial underway, because simvastatin is a generic drug. Nobody's going to make any money selling it. So it's hard to get the funding to do a proper phase 3 trial, which would involve many hundreds of patients followed for several years. But finally, that trial was supported by the National MS Society of the United States and the British equivalent. And the trial took many years to complete. And the sad news was that the results of the trial were negative. So simvastatin is not a useful agent for treating secondary progressive disease, but like many trials, even those that are negative, we always learn important things. And this data is just beginning to be analyzed and will probably teach us much more about secondary progressive MS. So that's the bad news about the clinical trial results that we heard from ECTRIMS. I'm going to turn this over now to my colleague, Dr. Stephen Krieger, who's going to give you some better news about clinical trials.
Well, I appreciate the opportunity to be here, and especially since I get to share good news, positive data with all of you. So this will draw from what you've heard so far. At ECTRIMS this year, perhaps the highest profile set of clinical trials to report were the phase 3 trials for a drug called tolebrutinib. Tolebrutinib is one of a new class of medicines that's being developed in MS. It's a pill. It works differently than any of the disease-modifying therapies that we've had available over the past couple of decades. So this represents a different step in how MS might be treated. And, you know, I'm going to tell you about this because it was high profile at our conference. It is good news, but also because it was a big investment of time from our center. We participated in the trial of tolebrutinib for secondary progressive MS. This is a trial called the Hercules trial. And not only did we participate in it, but we were the highest enrolling site for the trial in the United States. We had 10 people, 10 patients that we take care of who have secondary progressive MS who agreed to be part of this trial. It's about a 4-year commitment that they undertook. And this was a placebo-controlled trial where they're taking this medicine and they don't know, and we don't know if they're getting placebo or the real tolebrutinib for that whole time until the trial finished, as it now has, at which point we learn and they learn what they were taking. Being in a double-blind placebo-controlled trial is a huge act of courage and faith and generosity on the part of the patients that participate in this, to put themselves out there, not knowing if they'll get any benefit from it, but knowing that it moves the field forward. And so at the late-breaking clinical trial session at ECTRIMS, we heard the results that Dr. Miller just presented, that the statin trial was not successful in secondary progressive MS. And then we heard that the tolebrutinib trial, the Hercules trial, was successful, that tolebrutinib did prevent the worsening of disability for people with secondary progressive MS, better than placebo. Now, when these trials are performed, one looks to see whether the drug prevents the risk of accumulating more disability. I think one thing that we all have in common here, those of us speaking on this Zoom and those of us attending this Zoom, is that we all wish that we had medicines that could reverse disability in MS, that could fix the problem. We don't yet. But what we also haven't really had up until this point are medicines that can prevent that slow accumulation of disability in people who are no longer having relapses, what Dr. Lublin referred to as PIRA, progression independent of relapses. And what was shown in the tolebrutinib Hercules trial was preventing that risk of accumulation of more disability, even without new relapses, of 31%. This was statistically significant, and the safety profile of tolebrutinib looks favorable, and this is going to be submitted to the FDA for review to consider whether this drug can be approved. But there are some fine print that we have to think about. Number one, in the clinical trial, or actually really the series of clinical trials that the company running this, Sanofi, was running for tolebrutinib, there were a small number of cases of liver failure. What became clear was that if someone's liver is going to be negatively affected by tolebrutinib, that happens very soon. It happens within the first 12 weeks, first 3 months on the drug. And so once that was noted, once it was recognized, they instituted weekly blood tests to look at liver function for everyone on the drug in the first 3 months. And then if someone switched onto the active drug in what's called the open label extension, they then had to do weekly blood tests to look at liver function. The good news from this was once that added screening was put in place, there were no additional cases of liver failure. Anytime the liver was irritated by the drug, it was caught early and the person could come off the medicine and their liver would be okay. So as the FDA considers this drug, tolebrutinib, to see whether it can be approved to prevent progression of MS, they'll really have to weigh the risks and benefits as it relates to the liver. But I want to leave you with the following anecdote, which is about our center's participation. One of our subjects, who uses a wheelchair most of the time outside of the home, she's had MS for a long time, during the period of time that she needed to have weekly blood tests to look at her liver function, she needed to go to France to take care of a family member. She needed to be there for 6 weeks. And to give you a sense of the level of commitment that she had and that our team had here, including our research coordinators, Claire and Nicole, they arranged for her to have a French visiting nurse come to her house in France to check her liver tests every week for that period of time to ensure that even while she was there, we would get these French reports of liver function to make sure that she was stable. We knew the name of the visiting nurses that would come to her little town in France. It's that level of hands-on, I think, care and dedication and participation in a research project like this magnified 1,000-fold to get a project like this done, but I think it speaks a little bit to the commitment of our patients, the kind of team that we've run here to make this happen. And it's a very positive step to have been part of a trial that was successful in secondary progressive MS, which remains, even in 2024, one of the great unmet needs in our field. So that is the good news update from ECTRIMS from Copenhagen regarding tolebrutinib in progressive MS.
And now we're going to hear from Dr. Lana Katsan, who's the Associate Director of the Center.
Thanks, Fred, and thanks everyone for being here. I'm sorry for my voice today. So as I looked through and thought about the different presentations that I saw at ECTRIMS, I tried to think about which were the ones that I thought had a clinical impact. So which are the ones where, even if it's a small study, could be things that are going to be really important to the daily discussions that we have with all the people that we take care of. And so that was how I chose these two that I wanted to tell you about today. So the first one is a study that was run by one of our colleagues, Dr. Riley Beauvais at University of California, San Francisco. She was the lead investigator on this study. It was called the Sopranino study. And it was a very small study of women who were breastfeeding and receiving treatment with ocrelizumab or Ocrevus. And this is a really important study because we know that about 70% of the people that we care for are women, and most of them end up being diagnosed with MS between the ages of 20 and 40, which means that reproductive issues are really, really important in all the discussions that we have in terms of care. And it's really not even that long ago that women with MS were advised not to have children. So we've come a really long way, I think, over the past few years, but we still have more work to do. And a question that often has come up concerns breastfeeding and how to handle that. So we think that breastfeeding itself is somewhat protective against relapses, but we've known for a while that the postpartum period is a vulnerable time. And so we really do want people to go back on disease-modifying therapies as soon as is possible. So this study was really nice because it was done prospectively. So people were enrolled prior to the start of their breastfeeding. And the study was designed to measure not only how much ocrelizumab was in the breast milk, but also actually to look at the infants. And so 13 mothers were enrolled into the study. The first postpartum infusion that people got on average was about 2 months from the time of delivery. And 8 of them had also received Ocrevus before they conceived. And what they found was that the ocrelizumab levels in breast milk were really negligible. So we give women a dose of 600 milligrams of ocrelizumab. And what they found on average in the breast milk, in terms of the average infant dose, was 45 micrograms. So that's an entire order of magnitude less. The average relative infant dose was therefore 0.3% in the milk. Then what they were able to do, so then the milk has to go into the baby's GI tract, where of course it gets processed. And so then they were able to look at blood samples from 9 of the infants. And in all 9 of those infants, the levels of ocrelizumab were completely undetectable in the baby's bloodstream. So that tells us that these infants are really not getting exposure to Ocrevus when mom is breastfeeding. The infants also did well clinically. Obviously, this is a very small study, but an important thing to look at that people would be worried about would be infections in the babies. And their B cell counts were normal, and their infections were in line with general population, all resolved. Normal stuff. Of course, infants get a lot of infections, but nothing really out of the ordinary that gives us a safety signal. So I thought this study is something that, and this is preliminary, their study's ongoing, there's going to be more that comes out of this, but I thought this is really nice for us to be able to discuss with people that we're taking care of now. The other study that I wanted to highlight was a study that was presented by Dr. Amber Salter, and she's at the University of Texas Southwestern. So there have been a number of studies that have shown a link between different comorbidities and clinical outcomes in MS, comorbidities being just other health conditions that people have. So we know that having MS doesn't mean that that person is now exempt from having other health conditions. And actually, in fact, studies have shown that people with MS tend to have more other health conditions than the general population. And it's something that we can really do something about. So I think this is really important. So what Dr. Salter and her team did was they put together data that were collected from multiple phase 3 clinical trials for MS disease modifying therapies. They actually were able to collect data from 17 clinical trials, like almost all the clinical trials that have been run in the modern era. So this included it was 17 clinical trials, nearly 17,000 participants. And it's nice to use clinical trial data because, as Dr. Krieger was just saying, everything is collected in a very regimented way. And so we really get a lot of information out of these. And so they looked at things like cardiometabolic comorbidities, like high blood pressure, high cholesterol, ischemic cardiac disease, autoimmune conditions, psychiatric issues, migraines, skin conditions. And what they did was they looked at time to first evidence of disease activity over the 2-year period of the study. And so they looked at whether people had the timing to having a new relapse, to having a change in their MRI, or to having worsening of their disability level. And they were able to, because they had so much information on all these people, they were able to adjust the models for things like age, sex, which treatment they were assigned to, their baseline level of MS-related disability. And so the punchline of this study was that those who had at least 3 comorbidities of any type had a 14% increased risk of having an earlier time to having evidence of disease activity. And those who had just 2 cardiometabolic risk factors had about a 21% increased risk, which is really significant. And then there's a lot of really nice detailed information. They actually subsequently published a paper on this topic. But really, I think the takeaway is that the cardiometabolic comorbidities are really important, and we should really be paying attention to them. And so I think this kind of helps confirm the importance of a lot of the work that we're doing here at our center to make sure that we are asking people about these conditions, especially when they come through our comprehensive eval program, and really trying to address these through our wellness program that takes a really holistic view of people and tries to, manage things as best we can from all angles. I think we're back to you, Fred.
And maybe I'll just quick remind folks that you can use the Q&A function to submit live questions, although I know we have a whole bunch of questions that many of you submitted ahead of time that I think, Fred, you're going to start moderating with at the moment.
I am. So thanks, Alana and Stephen and Aaron. I have some questions that were sent in advance that I will triage with my colleagues here. The first is, what challenges arise in diagnosing MS or NMOSD in children due to their rare occurrence and overlapping symptoms with other conditions? And I'm going to strain Alana's voice a little more by asking her to take that on.
Yeah, sure. So children versus, So one of the first things we learn in medical school when you go to your pediatrics rotation that they're going to tell you is that children are not just small adults, because it's tempting to think that they are, but they're really not. And so it can be really, really challenging. So not only do the conditions present a little bit differently sometimes in children than they present in adults, the differential diagnoses of the other things that we have to think about is very different in children compared to adults. And I think those are probably the main challenges. And yes, the fact that these are rare conditions, especially NMOSD, is, we're already talking about an extremely rare disorder, and in children even more rare. That can be very, very challenging to diagnose. We are extremely fortunate here to have just added to our faculty Dr. Rachel Zono. I'm not sure if people were able to see the newsletter that went out today, but she's highlighted there. We're very excited to have her, and you really, I think, in my opinion, really do need to have someone who's really an expert in these conditions, and specifically the pediatric population, to be able to deal with these challenges.
Great. And continuing on, Alana, next is, are there ongoing clinical trials focused on MOGAD treatment or prevention of relapses?
Yes. So this is also a challenge because it's a rare disorder, and there are currently no FDA-approved therapies for MOGAD. Yet we're kind of in a similar position that we were in with aquaporin 4 positive NMOSD a few years ago, where there are therapies that we know do work. And so it makes the design and enrollment into clinical trials really difficult. This was something we encountered with the NMO clinical trials, and why we ultimately decided as a center not to participate in some of those, because they were placebo-controlled trials. And although the therapies we had were not FDA approved, and we realized some of them might not be as good as those being studied, we didn't feel like, from an ethical standpoint, each of us didn't feel like we'd be able to sit in front of one of our patients and advise them that it would be in their best interest to participate in the trial, which, Dr. Krieger alluded to the commitment that it takes to be part of a clinical trial. And so we had ultimately decided not to participate in those. For MOGAD, I think people are facing some of those same challenges, but there are some trials now. And so one is the meteoroid study. I don't know if people are familiar with that, but it's satralizumab. Satralizumab is known as Enspryng. It's a medicine it already has an FDA approval for NMOSD. It's an anti-IL-6 receptor agent. And so that's something that we all feel comfortable using in NMOSD, and there's some question about whether it might be effective for MOGAD, and so there's a trial going on there. And then there's another trial called Cosmog, which is of an agent called, the people refer to as Rosamab. I'm not even going to try to tell you the entire name of that antibody, but that one works by depleting immunoglobulins. And so at the end of the day, the mechanism is thought to be kind of similar to what we currently often use, which is IVIG. And so those are kind of the main trials going on now for MOGAD. But I think we're going to learn a lot more about this disorder through these trials over the next few years.
I'm going to throw this one to Aaron. What ethical considerations arise when deciding to escalate immunotherapy in critically ill patients? Yeah.
Well, that's kind of a somewhat amorphous question. So I think the ethical issues in that circumstance are not in principle different from the ethical issues we face in treating any patient, which is balancing the potential benefit versus the potential risk of a particular agent. And in some circumstances, we can make a pretty good judgment about what the potential benefits and the potential risks are, because we've had the knowledge that's gained from properly designed and conducted phase 3 clinical trials. In other circumstances, we tend to rely on anecdotal experience and the sort of collective wisdom that we've achieved through years of practice and in engaging with colleagues. But when we're faced with a patient with critical other conditions, then they're going to be much more at risk for the complications that come with a particular therapy. For example, the B-cell depleting therapies, which currently include Ocrevus, ocrelizumab, Briumvi, ublituximab, and Kesimpta, ofatumumab, and the older agent rituximab, which is not approved but is used a fair amount in some places. Those drugs which deplete B cells are known to carry with them a greater risk of infection. In fact, there have been a couple of published studies, well, one published study and one study that was presented at ECTRIMS that looked at all of the hospitalizations in the UK over the last decade in patients on a variety of different MS disease-modifying therapies. And ocrelizumab was the one that stood out as having a high admission rate for infections. So, and when you look at older people and people with underlying serious illnesses, they're much more at risk. And so personally, I'm much more hesitant to use those types of drugs in patients with these illnesses. But to reiterate, I think the fundamental principle is the same: balance potential risk versus potential benefit.
Let me keep you, because there's another question here. Is there any new evidence for discontinuing therapy after 5 years on treatment with stable MRIs?
Yeah, so we've known for some time that inflammatory activity in people with MS, excuse me, decreases as people get older. We see far fewer relapses in people with MS as they get older. We tend to see fewer new lesions on MRI. So we participated in an important trial called DISCO MS, in which a very select group of patients, those who were at least 55 years old, those who had been on continuous treatment with a disease-modified therapy for at least 5 years, and who had had no relapses for 5 years and no new MRI activity for at least 3 years. In fact, at the beginning of the trial, there was no MRI activity for 5 years. We took half of those patients off medication and left half of them on, in the hopes that we could establish non-inferiority, that it wasn't, excuse me, any worse to come off than to stay on. The trial to which we contributed the most number of patients, roughly 40 patients out of the 250 odd who were in the trial. Almost nobody in that trial had any relapses, but a few more patients in the discontinuation group had new MRI lesions. It was still only a relatively small minority of the patients in the trial who developed MRI lesions, and these were almost always either one or two small lesions. So my take-home message from that I give to patients who are in this category, people who are older, who have been on medicine for a long time and are very stable, is my advice is, look, if you really don't like taking this medicine, you're probably going to be safe if you come off it and we continue to monitor you clinically and with regular MRIs. If you're somebody who feels, well, I could take it or leave it, the medicine, I'd rather maybe not be taking it, but it's not a big deal, then you're probably a little bit safer to continue on the medication. So that was probably the best of the current studies on this subject. There have been others, and there's still some other ongoing studies looking at the risks of discontinuing medication.
Okay, thanks. And so a very dear friend of mine from my years in Philadelphia is asking, what is the latest update of BTK inhibitors in MS? And Stephen, you started talking about this. You want to give them the rest of the story?
Sure. So the BTK inhibitors is the class that tolebrutinib, the one that we studied here and that I talked about, belongs to. But it's going to be a complicated period of time. Usually when a drug is coming through clinical trials in multiple sclerosis, it's sort of one of a kind. So when we think back to when Ocrevus or ocrelizumab was approved, it was the only B-cell depleter being studied at that time and got approved and was very successful. When natalizumab or Tysabri was being studied, it was the only one of its kind, and when it was approved, it was successful. With the BTK inhibitors, there's half a dozen of them, all in late-stage trials at the same time. And so this is going to become a little bit of an arms race, in a sense, for what is going to be successful in what context, to what degree, and with what safety profile that it will bring with it as we see which of these medicines are successful and get approved. So tolebrutinib succeeded, as I talked about, in secondary progressive MS. Where it didn't succeed was in preventing MS relapses better than one of our existing approved medicines, which is called Aubagio or teriflunomide. Now, it's not that tolebrutinib, the new drug, didn't prevent relapses. It simply didn't prevent them better than Aubagio. And in the world of clinical trials, a tie is a lose because the drug has to show that it's better on the outcome that's being studied in order to be considered for approval for that indication. So tolebrutinib's complicated because it failed to prevent relapses better than medicines we already have, but it succeeded in preventing accumulation of disability, progression, in the absence of relapses. On the other hand, a different BTK inhibitor a few months earlier called Evo failed to prevent relapses better than Aubagio, same kind of outcome, but it wasn't studied to prevent progression. So we'll never know if that might have occurred because once a drug fails in its phase 3 trial, it essentially can't move forward. So we have one fail, we have one success in progression, and there are several other trials of these medicines that are going to come to fruition over the course of the next year. One of them, again for tolebrutinib, the same one we studied, will look to see whether it is effective at preventing progression for people with PPMS, primary progressive MS. At the moment, we only have one drug, Ocrevus, approved to treat that to prevent progression. So it's a big area of unmet need. That trial will report out in the summer. We're also participating in that trial here. We have a few patients who are in it, and so we're eagerly awaiting that one to be concluded and report out as well. At the same time, several other BTK inhibitors are going to report their results, including one of them being studied head-to-head against Ocrevus, which is interesting. Another one being studied in relapsing MS, and we are looking at several others to consider whether we'd like to participate in those clinical trials here too. And that brings back some of Dr. Katzand's earlier points. If we're going to agree to do a trial, we need to believe in the drug. We need to think that the trial is effectively designed. We need to feel that we could ethically bring our patients into it and ask them to make that kind of commitment and commit ourselves to it. So we're still looking at that in other BTK inhibitors. But a year from now, we'll know a lot more than we do at the moment. And it's possible that a year from now, tolebrutinib might already be approved.
And Stephen, let me keep you on here because there's another question. Are there any new emerging treatments besides Ocrevus that can help slow progression of primary progressive MS?
Well, that relates very much to this BTK inhibitor world. So there aren't at the moment, although the success of tolebrutinib in preventing progression for people with secondary progressive MS bodes well, I think, for its ability to do the same for people with primary progressive MS. There's debate in our field as to whether PPMS and SPMS, primary progressive and secondary progressive, are really different, or if they are, in fact, essentially the same thing. So if tolebrutinib is approved for secondary progressive MS, perhaps it will find usefulness in PPMS as well, and we'll see those results next year. Fenebrutinib is the other BTK inhibitor that's being studied in PPMS versus Ocrevus. So we'll really see there whether that drug succeeds and maybe even bests Ocrevus at preventing disability for people with PPMS. I feel like that's a long shot. Ocrevus already does work. It is not perfect for this, but to try to be better than the thing that's already approved is a big ask. So we'll see what that trial shows us probably mid next year, mid this coming year, that is, since it's already December. And there are other studies being done for progressive MS, but they're further afield. And I think it remains, again, the big need in our field. In a sense, things that alter progression may not always be drugs. They may be lifestyle interventions as well. I think it relates to work that Dr. Katzand and Dr. Samowski and others are doing here in our center, trying to alter the trajectory of the disease by boosting reserve through dietary modifications, Mediterranean diet, and other wellness endeavors. I think that has as much potential, to be honest, in boosting brain integrity and altering the trajectory of disability, perhaps as much as medicines do. And their work is going to source that out over the next couple of years as well.
You want to say a word about frexalimab?
I am happy to say a word about frexalimab. So I stayed true to the letter and spirit of that question, which was things being studied for primary progressive MS. But I'm very happy to say a word or two about frexalimab because we're very engaged in that as well here. So frexalimab is a new molecule with a new mechanism of action that's being studied in both relapsing MS and in secondary progressive MS. It works by changing the way different immune cells in the immune system can talk to and activate each other. So unlike other medicines that deplete away one type of immune cell, this changes, in a sense, the crosstalk amongst them. So it's perhaps less of an immune suppressant, but there's reason to think that it could be very useful in altering both relapsing and hopefully progressive MS as well. So we are participating in the frexalimab secondary progressive MS trial. It's very similar to the Hercules trial. It is drug versus placebo. It's looking at people with progressive MS who are no longer having relapses to see if it can help to prevent some of the risk of accumulating more disability. It's an infusion given once a month. We're doing it here at our clinical research unit, which, if you've ever been past Mount Sinai, looks like a lunar landing module that is permanently stationed outside of the hospital where we conduct our infusion clinical trials. We already have 5 committed participants at Mount Sinai in the frexalimab secondary progressive MS trial. We are tied for #1 in the country with those 5, and we're continuing to look for other people who would be a good fit for it and are willing to commit the time and effort for the next few years to be part of that trial. So I'm optimistic about frexalimab as well, but that'll be a few years from now before we have the results from that work.
Okay, and there's a two-part question. It says, are you aware of research about MS symptoms that happen outside of major episodes? And the second part, any updates on gut health connection? I'll take the first. So that's the PIRA, the progression independent of relapse activity, which are the MS symptoms happen outside of major episodes. This gradual worsening, it's a part of the progressive MS course. And so all of these progressive studies that Dr. Krieger has discussed are going to focus primarily on that aspect of the disease. And so we have an idea how to approach that, and I'm hopeful that we'll have better information on that in the coming years as these studies report out. And in terms of gut health connection, I'll turn it over to Alana.
Sure. So yes, a lot of new research going on in terms of gut health connection. So what we've learned so far is that it's pretty clear that the gut microbiota, so the bacteria that live in the gut in people with MS, is different than that collection of bacteria that live in people who don't live with MS. The part that we have yet to figure out is what that means from a clinical standpoint. We don't entirely understand what directionality this has. So is it because people have MS that the MS pathology is actually driving the differences in the microbiota, or is it the other way around? And is it the fact that because people have this different gut microbiota, are these changes actually driving the MS disease process? We've gotten a lot closer to understanding causality, and our animal model experiments have helped us a bit. We have been able to show that, for example, taking fecal matter from a person who has MS and transplanting that into mice, the mice get much worse. Our animal model of MS, or they get much worse mouse MS than if we take fecal matter from someone who doesn't live with MS and transplant it. So those kind of experiments have helped us get closer to establishing causality. The next question is, well, is there something we can do to manipulate the gut microbiota? And there are many ways we could do that. One would be through the use of antibiotics or probiotics. Another is by, manipulating other things that have big impact on the gut microbiota, like diet. And so those are topics that we're really actively researching here. So our wonderful colleague, Stephanie Tanku, is actually running a clinical trial here for people who are newly diagnosed with MS. Before they start their usual traditional disease-modifying therapy, they're randomly assigned to be treated with oral vancomycin, which is an antibiotic, or with a placebo for 30 days before they start their treatment. And 30 days is about how long it tends to take us to make a decision about the disease-modifying therapy, get the insurance approval, get it scheduled or started, so people don't lose time, which is really nice. So it's a great study. And there, what she's trying to look at is what is the impact of giving vancomycin on the microbiota? What impact does that then have on the peripheral immune system? And hopefully will lead us to understand what impact that has on the brain. So that's a really interesting study that I think is going to help us learn a lot more about these bacteria. This was based on some animal model work that she already did, showing that giving vancomycin seems to promote beneficial bacteria and get rid of some of the ones that might be harmful in MS that she did in mouse models. So I think that's a really great study that we're going to learn a lot from. And then we've done a lot of work here already on diet and hoping to move forward with more interventional clinical studies going forward. But diet is the biggest driver of gut microbiota composition in adults, in addition to all the exposures we all have as children and our genetics and things. Diet is really the biggest driver in adults. And so the more work we do there, the stronger that connection gets. And happy to talk, more offline about these topics, but making really good progress.
So while you're,
Fred, if I might circle back to one of the earlier questions, which was about stopping medications, and just talk very quickly about another study that we've started participation in, and that relates to one of the B-cell depleters, Ocrevus. And the way we currently give that medication is you take it indefinitely. It's an intravenous infusion every 6 months, but we don't stop it. But there, as I've already said earlier, there are risks to that medication. So there's a lot of interest in trying to find out whether people need to continue to take that medicine indefinitely. And we're participating in a study in which newly diagnosed people just starting on Ocrevus are randomly assigned to either take the medicine through the full 4 years of this particular study or to stop the medicine after 2 years, because there's some thought that administering this class of drugs may result in a reset of the immune system so that people don't need to take the medicine for so long.
coming back to Alana, there's a family question here on how to improve memory and cognition.
Sure. So I think there's a couple of different things to consider. One is that what we have learned is that things like brain games on the computer and all of this type of training stuff doesn't really have the impact that we all wanted to see. And so that's kind of the first part that's been a little bit disappointing in the field. Our disease modifying therapies do seem to protect against cognitive decline, but only partially, again, not as well as we'd like them to. What we have learned can be really helpful, and something that we are able to provide through our neuropsychologists that we have here, for example, are working on techniques that we refer to as compensatory. So these are types of techniques like how to use notes, how to use reminders, different organizational systems that can help people get through their day, do the things that they need to do, and can really have a big impact in the quality of someone's life. So I think those things are really important. But what we'd all like to see is more work on how to really treat this in terms of not only slowing down the progression of cognitive issues, but actually reversing them. Those are the things that I think we're all really interested in. And so the things that we can do are we can make sure that we optimize everything we can optimize. So that's the first thing. So treating mood issues, for example, making sure that we're being really proactive about treating issues with sleep and fatigue. And in my experience with running the wellness program over the last few years, I've seen such a huge impact of just dealing with those issues that a lot of people don't think make a really big difference, but they really do in terms of cognitive ability and symptoms of fogginess during the day. So those are really helpful. And then in terms of research, we've learned a lot over the past few years in terms of lifestyle factors like diet and exercise. We actually had presented a study at the American Academy of Neurology that we've done here, and hopefully should be published pretty soon, looking at an association between people's dietary habits and their cognition. And even after controlling for all kinds of demographic factors and health-related factors, what we found is there's a really strong link between people's dietary habits and their cognitive abilities, specifically related to MS. And so we think that's something that could also be helpful. Exercise is another huge area that people have been working on. Some of the results have been a little bit disappointing, but on review of the studies, all of these studies really are too small and too short, I think. What we're all hoping for is to improve what we refer to as plasticity. So the ability of the brain to change and in part, repair and kind of get around things, develop new connections. And so we really hope that exercise is something that can stimulate that. We know that it's helpful for other conditions. And so I think we need to do a lot more research in MS on these areas. There's been a little bit of work on medications, but none of them have been really successful. And that's all kind of consistent with our clinical experiences, having tried these medications for people as something to try. So I think nothing super exciting just yet, but a lot of work being done, and I think more to come.
Okay, a question here, how possible is it to give patients a sense of how their disease will progress over time? So my colleague here, Dr. Miller, has a whole slide set on quotes about the difficulty of predicting the future. That's certainly true in MS. There's no more serious neurologic disease that's as unpredictable as multiple sclerosis. That's the good news in that most of the other neurologic diseases are predictably bad. In MS, it doesn't have to be that way. We take our best guess when we see someone based on their history and their clinical presentation and their MRI. But in general, it's very hard to know. However, in the modern era now of high efficacy medications, I personally take a much more optimistic view of the future for patients. Fairly confident that we can get them through most of the serious aspects of the disease. Not for everybody, but for a much greater percentage than was true 10, 15, 20 years ago, when we didn't have as many highly efficacious agents. So predicting is hard. What I tell patients is over time, you'll see that you're doing well and that you can put this out of your mind to a degree. And as we develop more and more of these therapies, we'll be even more optimistic. I'm going to throw the next question back to Dr. Miller because it's the opposite side of the coin of what he discussed earlier with discontinuation, and that's anything on the horizon for those of us past the age of 75.
I have a couple of mugs in my kitchen cabinet that say "Old Lives Matter." There's nothing arbitrary about age with regard to the treatment of MS. I'm happy to say I have a couple of people 93 years old in my practice. These medicines, there's no evidence that the medicines stop working at a particular age. It always becomes a matter of the risk and the benefit. To add to what Dr. Loveland just talked about the prognosis, I think actually that we're not all that bad about prediction, and we're learning more and more. So we know some of the signs early on that might portend a worse prognosis, but the good news is now we have a lot of effective medicines that are altering that prognosis, and so that if we see those indicators that might suggest that a person without treatment might be destined to have problems, we're going to be more inclined to use a highly effective therapy from the get-go in those patients. Also, we learn, I think one of the best predictors of how somebody's going to do in MS is how they've been doing. So somebody who for a number of years has been doing well is going to probably continue to do well, and you can gain some reassurance from that. But with regard to age, you don't go by the age. You go by what's the person's general health status, what are the risks of a particular medicine that you're going to give, balancing the fact that we know that inflammatory disease diminishes during age. Do we really need these medicines to control inflammation if that's going to be declining anyway? We haven't yet. Tolobrutinib notwithstanding and not yet on the market. We haven't yet found a medicine that actually impacts the insidious progression. So we might want to take those medicines away from somebody who's got comorbidities and is gradually progressing. But I don't use age as an arbitrary figure.
Okay. Unfortunately, the agents that get tested never get tested in that particular age group. And that always adds to the issues that were discussed earlier about the effects of comorbidities and just being older and taking what may be powerful medications. But it is an unmet need as to how best to deal with individuals that age. Fortunately, MS tends to really slow down, if not stop, once you get into the 70s and 80s and such. And we take actually a a much more cautious approach to disease at that point, because usually what's going on is related to other medical problems. There was a question that was sent in about medication refills. We can't answer that. And there's a question about, can you recommend a support group? Our social workers can, the National MS Society can. Lana, anything more we can answer for that?
No, I think the National MS Society remains a really great resource in terms of support.
I think all the questions that were in the Q&A were answered separately.
And actually, Dr. Levin, we're right at time. So maybe if I'll take the liberty of just throwing out one last question. Again, this serendipitously taking place on Giving Tuesday. Where is additional funding needed to do the work of the center? Where would you all love to see you take the work that you've described, and even some of the work that you didn't get to describe today? Where's the bottleneck for you all?
So funding is always a bottleneck. As a comprehensive MS care center, we're dealing with multiple aspects of the disease. And so we do use the philanthropy that we have for ongoing studies that are being done by individual investigators. We use it for the wellness program, which we want to expand because it's a wonderful program that patients really like. We do it for support services to help pay for the things that aren't chargeable, aren't billable, things like social workers. Much of the medical assistants and even nurse practitioner time ends up being uncompensated. So just to be able to provide the clinical care, the clinical research, the more basic research, and the educational activities that are all part of our remit as a comprehensive care center, the philanthropy greatly assists all of that. And another thing that it does that probably isn't obvious from day to day, but it lets us provide all the time that any individual needs. And we don't have to stop at 15 minutes for a follow-up visit or such like that. And no one's knocking on the door saying your time's up. And that's precious time that we spend with patients, and it allows us to really give superb care.
Anyone else want to add to that before we close out? Dr. Katsan?
Yeah, I of course agree with everything that Dr. Loveland just said, and we are so appreciative of everyone's support that allows us to do the work that we do every day. I think two quick things that I would highlight is from a research standpoint, budgets are being cut left and right. So I don't know if people are aware of this, but when you apply for the NIH, and if you are lucky enough to be in the small percentage of grants that get funded, the National Institute for Neurologic Disorders and Stroke, which is where most of us get funding from, they right away slash your budget by 20% of what you asked for, just as an administrative cut before making any other cuts. So it makes it hard to be able to do the work. The National MS Society, who we really rely on a lot for funding, unfortunately, their own funding has really been cut over the last few years. And so what they have available for research has really dwindled, meaning that less and less important studies are getting funded. And those that do, the budgets are a lot smaller than they used to be. So it really helps us so much when we're able to rely on philanthropy to kind of fill those gaps so that we can still do all this really important work. And the other piece that Fred mentioned, but I do want to highlight, is the educational part. So our fellows are wonderful. Hopefully many of you have met many of them, but they are the future. And again, funding for us to be able to train them has just been cut and cut over the years, and the opportunities have become less and less. And so we all here think it's really important for us to continue training the leaders of tomorrow in this field. And that's another area where I think the support really makes a difference.
Well said. And
I would like to add, Tom, that thanks to Kathy Diaz and yourself for organizing this. And certainly thanks to everyone who joined us. We had a very nice participation. And so we're glad, and we will continue to do this periodically so that we can continue providing education and support.
Oh, that's wonderful. So I will, with that, close us out. Again, thank you all who attended. There will be a recording available. Again, it is Giving Tuesday. This QR code on the screen we'll make sure that any donations that you're inspired to make go directly to the Corinne Goldsmith Dickinson Center for Multiple Sclerosis, and all the amazing work that the faculty, the staff, everyone continues to provide, not just for the patients that we see at our center, but as it impacts the future of MS care worldwide, really. So with that, thank you all. Have a good evening.
Wishing everyone great holidays.
Thank you, everyone.
Thanks, everybody.